Hi, I'm Polly Hansen, a producer of Radio Health Journal. In this podcast exclusive episode, you'll get an inside look into my conversation with John Green, author of the best-selling novel The Fault in Our Stars. The success of that novel has allowed Green to write nonfiction books on topics he cares about deeply. His newest book is titled Everything is Tuberculosis. We start our conversation with why he gave it such a quirky title.
Well, my wife often jokes with me that in my mind, everything is about tuberculosis and tuberculosis is about everything. And that's very true. Like history is tuberculosis, geography is tuberculosis, colonialism is tuberculosis, literature, art criticism, it's all TB. And so when I look at the world, I really do look at it through the lens of tuberculosis.
But what happens when you go see La Traviata?
There you go. A great example of TB being at the center of our culture. You know, I think TB is often used in art or especially in narrative art, as a narrative device, because as a disease, it sort of lends itself to art because it moves fairly slowly. And so you have time to get connected to the characters before the characters eventually pass away of their illness.
We'll get into that in a little bit. So tell us about Henry and how you met him.
Sure. So the book really centers on my friend Henry Ryder, who is a TB survivor living in Sierra Leone. I met Henry in 2019 when I visited Le Cas Government Hospital, the only TB hospital in Sierra Leone. And I was taken around the hospital by this lovely young boy who shared the same name as my son. And I was immediately charmed by him. He's extremely charismatic. He was like the mayor of that hospital. Everywhere he went, people were shaking his hand and rubbing his head. And he took me to the kitchen and took me to the lab and took me to the wards. And eventually we made our way back to the doctors I was traveling with, and they kind of shooed him away in a loving fashion. And I said, "Whose kid is that?" Because I figured he had to be the child of a healthcare worker. And the doctors explained that, in fact, he was a patient, and he was one of the patients they were very concerned about because while he was responding with the antibiotics, that's why he was able to walk around and be relatively healthy. They could tell from the tests that he wasn't responding well enough and that his TB would inevitably come back.
I just want to segue a little bit into a personal story. I know the sanitarium, or what used to be the sanitarium, where your grandfather, was it your great-grandfather?
My great uncle, yeah, my grandfather's brother.
Your great uncle. Okay. So I was at the grocery store and there's this old man. He looks homeless and he's asking for a ride home. So I took him home and he drives. I live in Asheville. He took me around the back roads and he said, "You know, this place used to be a sanitarium, a TB sanitarium." And I said, "Oh my gosh, no, I didn't." So it's
Wow.
apartment buildings now. So I know exactly where your uncle was being housed. So
That's amazing.
was that how you originally got interested in TB? Was your family connection?
No, I didn't know about the family connection until I'd already been researching about tuberculosis for years. And then I was telling my mom that I thought maybe I was writing a book about TB. And my mom said, "You know, your great uncle died of TB." I had no idea.
Oh my
And
God.
then she showed me my great grandfather's memoir where he talks about it. And I was like, oh, because my mom's a bit of a storyteller, also a product of Western North Carolina. She lived in Fairview for a long time. And I, just like me, I'm a storyteller as well. So I was like, "Oh, yeah, I'm sure he did, Mom." And then she showed me, and I was like, "Oh, wow, he really did."
Yeah, it's in your blood. Thank
It
God.
is, yeah. I mean, it's in most of our blood, is the truth, because this is a disease that's killed 1 in 7 people who ever lived. And, in the late 19th, early 20th century in the United States, it was killing, 1 in 5 or 1 in 6 people. So most of us, if we trace back our histories, have a lot of TB in the past.
Have you had your blood tested just out of curiosity to see if it's there?
Yeah, so because I, travel a fair amount and spend a lot of time with people living with tuberculosis, I do get tested pretty regularly, and I've never had a positive test. But, the thing is, if I do, this is a curable and preventable illness. And so if I do, I would get preventative therapy and have no problem clearing the infection from my body. This is what I find so frustrating about tuberculosis, is that someone like me can regularly access testing, can regularly access treatment if I need it. And I don't have anything to fear from tuberculosis, really. But for so many people, that's just not the case.
Well, let's go back and talk about why TB was romanticized at first.
Yeah, so in the 18th and 19th centuries especially, we did really romanticize tuberculosis. We saw it as an ennobling disease, a disease that made you more beautiful, especially if you were a woman. This is a time when the sort of frail, thin bodies came into vogue, rosy cheeks to mimic the hectic fever of consumption, sort of sunken, wide eyes. People would sometimes apply belladonna to their eyelids to give them that sort of wide-eyed, consumptive look. And for men especially, but also to some extent for women, it was also seen as a disease that made you a great artist, that made you more sensitive to the suffering in the world and more able to express beautiful sentiments in prose or poetry. Like Victor Hugo's friends joked with him that he could have been a great author if only he'd contracted tuberculosis. And of course, many poets did die of TB, but now we know they didn't die of TB because they were great poets. They died of TB because so many people were dying of TB.
Yeah. So then what happened to change that to make it a stigma and a stain?
I think TB was always stigmatized. It was just also romanticized. And then, especially after we understood that it wasn't an inherited illness, but rather a infectious one, we started to imagine the disease very differently. We started to see it as a disease of filth, a disease of poverty. I think one author referred to the tents where people living in tenements were unusually susceptible to tuberculosis because they were living and working in crowded conditions. And today we know that's really the reason why there was so much TB in the 18th and 19th centuries in Europe and the United States. It's that those places were industrializing. And as they industrialized, people were living in cities more. They were living in crowded conditions. They were often had poor ventilation in their factories. And that's what contributed to the spread of TB.
And then you write that wealthy people, don't worry about it. This is where we live, is where TB medications are. The medications are not where they need to be. But why is it dangerous for wealthy people to think, oh, TB, I don't need to worry about it?
Well, it's dangerous on a few levels. We have one human health. We share one globe. Pathogens don't know about political borders. They don't care about political borders. And we have 10,000 cases of active tuberculosis in the United States every year, and that number is going up. And so thinking that disease is going to respect political borders is always a misjudged COVID pandemic. I also think, though, that it's not just that, tuberculosis may come home to places like the United States or Northern Europe and reassert itself as a global health threat. It's that right now it already is a global health threat. This already is the deadliest infectious disease in the world. It already is killing over 1 million people a year. And so, yeah, we should be worried about an totally antibiotic resistant form of tuberculosis that spreads throughout the world and becomes this terrifying superbug. But for many people, for over 1 billion people, the superbug era is already here because they don't have access to the treatments that you or I would have access to, and they don't have access to the cure. And so I think we should worry partly because we have an obligation to our fellow human beings to value all human lives the same.
It's going up in the US. That's alarming. I mean,
Yeah.
I think it would be going down, not up. Are there pockets of it?
There are pockets. I mean, there was recently a tuberculosis outbreak in Kansas. We do a pretty good job. We still have relatively well supported, compared to deeply impoverished countries, well supported public health systems. They aren't nearly as well supported as they need to be, and they aren't as well supported as they were even a few years ago. But we're able to identify cases of TB fairly quickly. But right here in Indianapolis, where I live, somebody died of TB a few weeks ago. So it's not as uncommon as we think that it is. Like as is the case in the rest of the world, TB tends to follow the paths of injustice that we blaze for it. So it tends to disproportionately affect people who are living in poverty or who are unhoused. But anybody can get TB. Anybody who breathes air can get tuberculosis.
You talk about cost effectiveness as a frenemy. What do you mean by that?
Yeah. Well, of course, we have limited resources and we need to be smart in how we deploy those resources. But the obsession with cost effectiveness, I think, often misjudges the size of the problem. I'll give you one example. My friend Henry's tuberculosis cost about $900 to cure. And he was repeatedly told it wasn't cost effective to treat his TB because that $900 was simply too much money, and that it was better to focus on prevention efforts. Well, my little brother had cancer 2 years ago. Even though his cancer was very curable, it still would be more cost effective to focus on prevention efforts. We know that like preventing cancer is cheaper than treating cancer, and yet nobody said to Hank, like, I'm sorry, but we can't treat your cancer because it's more cost effective to prevent cancer. That's true. It is more cost effective to prevent cancer, but we should be doing both. And there's an expectation that we should provide care alongside preventative services. And I think that expectation is fair and appropriate and shouldn't only be fair and appropriate in wealthy resourced settings.
So let's go back to Henry and talk about why he was on death's door, what was going on with him.
So Henry had a complicated form of drug-resistant tuberculosis, which means that he didn't respond to the first or second line of antibiotics as well as he needed to in order to cure the infection. That also meant that somebody like Henry needed really a personalized, tailored treatment for just his tuberculosis. Anybody in the United States should expect to receive such personalized, tailored treatment, but in Sierra Leone, it was much harder. Henry was incredibly fortunate to have a doctor, Dr. Jérôme Tefera, who simply would not give up on him and consulted with physicians at Harvard and all around the world to try to find a drug regimen that would work for him, and then convinced the Sierra Leonean Ministry of Health to approve those drugs so that Henry could receive them. And you're right that Henry was on death's door. He was essentially on his deathbed. And then once he got the appropriate treatment, within a few weeks, Dr. Tefera said it was like a miracle. He just, got up off that bed and has been well ever since.
That is such an amazing story. It's incredibly hopeful and sad. I mean, so sad that
Yeah.
he had to suffer that much.
Yeah, I mean, Henry spent years in that hospital, and those are years that he should have been in high school. He should have been able to pursue educational opportunities. He knew how important education was to someone like him, living in poverty in a low resource community. He knew how much education could make the difference for him, and he knew what it meant to lose those years. Now, because he's an extraordinary kid, he's been able to finish high school, and now he's a college student at the University of Sierra Leone studying human resources and management, and he's very successful and doing really well and about to enter his senior year. But a lot of things had to break in Henry's direction for that to be the nature of his story. He had to have a lot of support, and that should be everyone's story. Everyone who gets tuberculosis should receive the kind of care that Henry eventually received, and they shouldn't have to wait years for it.
Right. So, how does your success as a novelist, how did The Fault in Our Stars ultimately help Henry?
I guess it did in a way because, the success of The Fault in Our Stars allowed me to, two things. First off, it allowed me to be more financially supportive of causes I care about, like Partners in Health, an organization that has helped Henry a lot and helped hundreds of thousands of other TB survivors. But secondly, it allowed me a lot of creative freedom. It allowed me the freedom to pursue what I want to write about and write the kinds of books I want to write. The Fault in Our Stars was the book that I felt deeply compelled to write when I wrote it. And Everything is Tuberculosis is the book that I felt deeply compelled to write this time around. And so having that kind of creative freedom is a real privilege and a really rare one, and something that I try not to take for granted.
So, I would like to know about the End TB Now Act before Congress.
Yeah, so there's an act before Congress now. I say this sort of laughingly because the scope of the challenge at the moment with Congress is pretty profound. But there's an act before Congress that would make it so that basically TB care becomes truly comprehensive. The TB care funded by the US government becomes truly comprehensive, which means active case finding, treating every single person you encounter who has TB, and then offering preventative care to their families, because we know how to prevent TB as well in people who aren't sick yet. And that act of Congress would be very powerful, but it's only powerful in a world in which we're still funding tuberculosis care. And right now, the U.S. has walked away from the vast majority of its commitments around treating tuberculosis. We know hundreds of thousands of people saw their treatment interrupted with the dismantling of USAID, and we know that those people have a skyrocketing high chance of developing drug resistance. Most of them, if they're not put back on treatment, the vast majority will die. But even if they are put back on treatment, the interruption in treatment leads to a much higher chance of drug resistance, which makes it much more likely that people will be in the kind of situation that Henry was in.
So, even let's assume that we go back to providing funding.
Yeah.
Will it be too late? Will the drugs that are now available no longer work on these people?
I think that is a real concern. It's a real concern that we could inadvertently create more complicated forms of drug resistance because we've, artificially created this interruption in treatment for so many people. And, the nightmare in the world of TB, of course, is a totally drug-resistant form of tuberculosis that we simply have no tools to address. And we've certainly increased our chances of living that nightmare.
I just was curious if you had ever heard of the book The Black Angels by Maria.
Oh, I love that book by Maria Smilios. Yeah, I love that book.
Her. Yeah, that was a fascinating story.
Yeah, I mean, it really is a beautiful story of the cure of tuberculosis, and it's so well written too. It feels like a novel. It's just very propulsive in its storytelling, and developing the cure for tuberculosis is one of the most impressive things we've ever done as a species. And we did it because we, oriented all these resources around trying to develop new lines of antibiotics. And between 1945 and I think 1965, we developed 7 or 8 lines of antibiotics that can treat TB. And then between 1965 and 2012, we developed none because we just stopped being interested in it. When it ceased to be a problem in the rich world, it sort of ceased to be an area of pharmaceutical development. And that's part of the reason why we're so far behind the curve when it comes to drug resistance.
Wow. Well, it seems like it's like hunger. We have enough food in the world to feed everyone.
Yeah.
We just don't.
Exactly. And it speaks to challenges that we have. I mean, I don't pretend that this stuff is easy or that these problems are easy to solve. I've seen them up close. They're incredibly hard to solve. Hunger is incredibly hard to solve for. Inequitable access to medication is hard to solve for. I don't want to pretend otherwise, but we know we can do it, right? Like we have adequate resources to do it. It's just that we've chosen to allocate those resources in a way that does not reflect what I think is a shared belief among humans that all human lives are equally valuable. And until we do that, we're going to live in a profoundly unjust world.
Well, John, we've covered a lot. Is there anything we haven't covered that you'd like to add?
No, this has been a wonderful conversation, though. I really appreciate it.
Great. Well, thank you so much. I'm glad you wrote the book. It was fascinating reading it.
Thank you again, and enjoy Asheville, one of my favorite cities in the United States.
Oh, thank you. Yeah, I'm looking at the mountains right now.
Oh God, it's so beautiful there. My parents now live here in Indianapolis. They moved here as they got older, but I miss when they lived in Western North Carolina. It's such a special place.
Yeah, my daughter and my son. Well, I lived in Chicago for 54 years.
Wow.
And I wanted to move here for 36. And my husband said, after 36 years, he said, okay.
That's great.
I waited a long time.
That's amazing. Well, enjoy it.
Thank you.